Greetings. I'm Danielle Mowry, Chief Research Information Officer at Penn Medicine. Today, I'm thrilled to introduce a new resource to facilitate Penn investigators' access to patient clinical data to advance our knowledge and understanding of COVID-19. On March 11, 2020, the World Health Organization declared COVID-19 a global pandemic. To date, COVID-19 has infected nearly 90 million individuals, resulting in over 1.9 million deaths worldwide. Unfortunately, these numbers will continue to grow in the upcoming months. Here at Penn, we don't need to look far to identify thoughtful questions posed by investigators searching for answers to limit the impact of COVID-19 on their patients and to save lives. Questions posed to identify COVID-19 testing deserts among our communities, to develop better tests for diagnosing COVID-19, and to develop treatment strategies for improving patient outcomes. For more information or to register your own studies, please see the Observational Study Registry at the link below. Given the breadth of interest and urgency of this research subject, we aim to adopt a database that could achieve the following goals. First, to provide timely and up-to-date clinical data about patients being tested for COVID-19. Second, to streamline data access for low-risk observational studies. And third, to facilitate the engagement in multi-institutional efforts while preserving the privacy of our patients. The COVID-19 Informatics for Integrating Biology to the Bedside database, or i2b2, will be available for use by Penn investigators at the end of January 2021. i2b2 is a query and analysis tool. Using the i2b2 web client, you may select and review patients locally based on past and acute clinical features, care management, among many other health details. You may review and export patient lists and counts for analyzing overall trends, given this is a limited data set, and includes temporal information to support longitudinal epidemiological studies. Queries within i2b2 are supported by its robust ontology. The i2b2 ontology encodes and standardizes COVID-19 related observations and clinical facts and was developed at the University of Pittsburgh. The ontology includes demographics important for studying disparities, specific course of illness information including conditions and severity classifications, important medication and care management events and procedures, as well as more detailed information about how a diagnosis was made, whether through aspects of clinical presentation or confirmed via laboratory tests. New data elements will be added to document whether and which vaccine was received by a patient. The i2b2 ontology relies heavily on codified EHR data using ICD billing codes, CPT procedure codes, and normalizing information to standardized vocabularies using vocabularies such as the RX norm and the Unified Medical Language System. The database contains over 150,000 COVID-19 Penn Medicine patients that have been tested and is continuing to grow. i2b2 is also a federated research infrastructure for supporting data queries through a distributed research network. Through the Accrual for Clinical Trials, or ACT network, and its Shrine Hub, you can query aggregate counts across patient sites, including partners, University of Pittsburgh, University of California, San Diego, among other ACT sites. The i2b2 infrastructure enables researchers to obtain a bird's-eye view of both our data and data from around the nation while protecting patient privacy. The individual data stays at Penn, and only aggregates can be queried from the network. The i2b2 database has already demonstrated feasibility of engaging in national and international collaborations. Through collaboration with other CTSA sites, we've participated in international efforts to fight COVID utilizing the i2b2 database in ontology, led by Dr. Zach Kahani and his team out of Harvard. The Consortium for Clinical Characterization of COVID-19 by EHR, or 4C, aims to inform clinicians and epidemiologists and the public about new insights about clinical course of COVID-19 patients derived from EHR data. Our early consortium efforts in the spring of 2020 involved working with about 40 participating sites representing 96 hospitals globally from North America, Europe, and Asia. We were tasked with collecting aggregate daily counts of affected patients, including their demographics, diagnoses, and labs. Across the consortium, we collected information for over 27,000 patients with COVID-19 diagnoses, including over 187,000 laboratory values, all harmonized across sites. We observed early abnormalities in laboratory tests representative of renal function, systemic inflammation, coagulopathy, liver function, and immune response, all of which is visualized relative to the data of diagnosis of COVID-19 shown in the leftmost panel. Through the 4C efforts, we were also working with informaticists and clinicians to define COVID patient severity phenotypes based on EHR data. For instance, this phenotype defines patient severity based on one or more documented EHR data elements, including laboratory tests, medications, diagnoses, procedures, all present in the inpatient record. For more information about these studies and more, please see the links at the bottom of the write-up. We are continuing to add novel information to the i2b2 database, again, including in vaccination information. At this time, the database contains only structured data, but our plans are to enrich this with text-derived variables such as symptoms and thrombotic events from clinical notes, and we'll aim to achieve this by the end of the spring. To help investigators get started with the i2b2 database, we will also have several training workshops throughout the spring of 2021. So you may ask, well, how do I get started? The i2b2 database will have 3 distinct data access workflows for supporting researchers. First is prep for research. Investigators can generate aggregate counts with no IRB. Second, for observational and non-interventional research, investigators can register their study and study personnel in a REDCap database, which will be covered under an umbrella IRB. Study teams will provide proof of human subjects training and attest to storing and analyzing data on Penn Medicine management machines, not sharing the data outside of Penn Medicine covered entity, and not attempting to re-identify patients. Once your request is approved, this will trigger elevation of views for patient-level data, enabling self-service queries through i2b2. Data will be provided to you and your team by designated honest brokers once an Athena ticket has been submitted. Importantly, all other research studies that request the use of i2b2 data that do not follow these criterion will require a Penn principal investigator-sponsored IRB, and again, will require an Athena ticket to request the data. If you are unsure whether or not your study meets the requirements and would fulfill the requirements for participating in the umbrella IRB, please contact the Penn IRB and an analyst will help you. Now that we know the rule of the road, to access the i2b2 database, you can access the data through the UPHS data portal from the link above using your UPHS account. Both i2b2 and Shrine icons are available to facilitate local and national queries. For those with more advanced data needs, the Institute for Biomedical Informatics Clinical Research Informatics Core will also be available to help. For data query and pool assistance, please contact me at my email address below. For account provisioning, please contact Nebo Merkovic from the DAC. We thank the Data Analytics Center, the Institute for Biomedical Informatics, the Institute for Translational Medicine and Therapeutics, the IRB, and our CTSA for their support and partnership in serving the needs of our Penn community with this valuable resource. Thank you.